All right. Well, my name is Linda Lee. I'm Medical Director of our Endoscopy Centers at Brigham Women's Hospital and Associate Professor of Medicine at Harvard Medical School. And we'll be talking about acute GI bleeding and other GI emergencies. As we all know, upper GI bleed refers to any bleeding that occurs proximal to the ligament of Treitz. Small bowel bleeding is anything between the ligament of Treitz to the ileocecal valve. And of course, lower GI bleeding is anything distal to the ileocecal valve. Occult GI bleed is when we cannot see the bleeding with our naked eye. However, hemoccult tests will turn positive compared to overt GI bleed that is visible to the naked eye. Obscure GI bleed refers to the fact that there's no source identified despite performing EGD and colonoscopy, and this can be overt or occult. Acute GI bleed has been going on for less than 3 days compared to chronic. Now, with respect to epidemiology, upper GI bleed, shown here in blue, is far more common cause of hospitalization in the US compared to lower GI bleed. And 80% of all GI bleed, however, stops spontaneously. The overall mortality rate is thankfully fairly low, although I do want to point out that the mortality rate for inpatients who are hospitalized for another reason and then start bleeding while hospitalized is significantly higher than patients who are admitted as outpatients with GI bleeding. Now, I like to think about handling all GI bleeding as A, B, C, D, and then E, endoscopy, is the very last thing that should happen. A, of course, refers to protecting the airway. B, ensuring adequate oxygenation. C, circulation of fluids. And the things that I've starred here throughout my talk refers to recommendations from the relatively recent ACG guideline on upper GI bleeding. They, as well as others, recommend transfusing when the hemoglobin goes less than 7. However, less than 8 if the patient is at increased risk of adverse events from severe anemia or if they're hemodynamically unstable. A goal hemoglobin of around 8 is reasonable if the patient has variceal bleeding. As far as D drugs go, we typically think of things that include IV PPI, erythromycin, octreotide, and antibiotics are those things that we administer for variceal bleeding that I will not be discussing today. Of course, we all start with a history and physical that's targeted and looking for a history of GI bleed, trying to make sure that they're look into their comorbidities to look for risk factors for GI bleed, as well as what may impact safety and sedating the patients for procedures. And as far as medications go, anything that may have caused a GI bleed, as you see here, although I do want to point out that we no longer recommend holding aspirin if it's being used as secondary prevention in a patient. I also want to point out to beware of the use of SSRIs in combination with NSAIDs, as there appears to be a significantly higher risk of upper GI bleeding with a combination compared to patients who use NSAIDs alone. As far as exam goes, certainly doing a rectal exam, assessing their abdomen, and then I want to say a word about INR. It does not need to be normal before doing a procedure, and we'll talk more about this later, but certainly do not delay your procedure waiting for reversal. In terms of assessing the severity of GI bleeding, there are many validated scoring systems to predict rebleeding, surgery, or mortality, in particular for upper GI bleeding. However, the one that has been recommended recently by the ACG guideline, as well as others, is the Glasgow-Blatchford score that predicts the need for endoscopy, surgery, and transfusion. And the statement is that if the GBS score is 0 or 1, those patients can be managed as outpatients. There are certainly lots of interest in AI and machine learning models. which seem to suggest that they may perform better at predicting the need for hospital intervention and mortality, although more research is necessary. With respect to lower GI bleed, the Oakland score less than 9 seems to predict safe discharge as well. But of course, these patients need to be reliable patients who will return within that next week for upper endoscopy or colonoscopy. Now, certainly we need to be aware that about 10% of all lower GI bleed ultimately are proven to have an upper GI source. And in the older days, we used to do the barbaric NG tube aspirate to predict upper GI bleed. As you can see there, the sensitivity has a wide range and not very specific. And using the NG tube did not seem to help the physician predict high-risk lesions needing therapy, decrease rebleed, or mortality, but as you might expect, has significant adverse events. And so we do not recommend routine placement of NG tube to try to figure out if it's upper or lower GI bleed. Now, capsule endoscopy may prove to be helpful in triaging patients. These are 2 randomized studies, one from Hong Kong, one from the US. And the Hong Kong study showed that patients who are randomized to capsule endoscopy versus standard of care, much fewer % of those patients ended up being admitted. The bottom chart is taken from the US study that shows that patients who are randomized to the capsule endoscopy arm had much faster time to localization of the bleeding source, and the bleeding source was identified much more frequently in the capsule arm versus standard of care arm. Now, very recently, there's this newer capsule called PillSense that is intriguing as it simply detects the presence of blood, as you can see here, once it's paired with this iPad-like display device. After the patient swallows the capsule, within 10 minutes, it'll either say, yes, blood is detected, or no, blood is not detected. And initial study has shown very high sensitivity or specificity for detecting blood when using EGD as gold standard, performed within 4 hours of patients swallowing this capsule. So this is certainly intriguing. It requires further study to help us understand whether it may help with triage, differentiating upper or lower GI bleed, and detecting rebleeding. So let's focus on non-variceal upper GI bleed. An overwhelming 80 to 90% of upper GI bleed are non-variceal. Still leading the pack in terms of etiology is peptic ulcer bleed. And you can see here on the right, evidence of esophagitis and what looks like mild GAVE below. Now, with respect to pre-endoscopy management, patients are usually reflexively given IV PPI, and we'll talk about this in a minute. IV erythromycin is recommended about half an hour to 45 minutes before endoscopy, has been shown to decrease the need for a second endoscopy because you could not get a good enough look with the initial one, as well as a potentially decreased length of stay. There's a recent randomized trial using IV metoclopramide that suggests decreased need for second endoscopy as well. Platelet transfusion should not be administered as it has not been shown to decrease rebleeding, and there is some suggestion that it may increase mortality. Now, looking at this issue of IV PPI before endoscopy, this is a randomized trial. And what you can see here is that of the clinically meaningful outcomes of further bleeding, mortality, length of stay, units of blood transfused, there was no significant difference between the omeprazole group versus placebo. The only thing that was different by administering IV PPI before the endoscopy is that endoscopic therapy was able to be rendered less commonly with the IV PPI compared to the placebo arm. Now, what about timing of endoscopy? All endoscopies should be done within 24 hours. And if you look on the right side of the screen there, this is showing you how when patients were randomized to urgent endoscopy performed within 6 hours compared to early endoscopy performed within 6 to 24 hours, there was no significant difference in mortality or further bleeding. And in fact, now if you look at the left side of the slide, patients who had upper endoscopy performed very quickly within 6 hours in this study seemed to actually have higher mortality rate that was attributed to patients not having been adequately resuscitated before a GI going in and performing the endoscopy. So again, very important to make sure that that's done before we perform the endoscopy within 24 hours. Now, what would you find on endoscopy? Well, you can certainly see clean base ulcer, pigmented flat spot, which are low risk for rebleeding, adherent clot, kind of modest risk for rebleeding, and then of course, non-bleeding visible vessel, active bleeding, significantly higher risk for rebleeding. And so those are the findings for which you should definitely perform some type of endoscopic therapy. And these are the options. So certainly thermal therapy with BiCAP or combination with injection of epinephrine with thermal therapy or with CLIP. And then those are the strong recommendations from the ACG guideline, and the conditional recommendations include monotherapy with CLIP, argon plasma coagulation, soft coag grasper, some type of hemostatic spray, and over-the-scope CLIP. Epinephrine monotherapy should not be used. So epinephrine alone is not sufficient for treating upper GI bleeding. Now let's talk a little bit about thermal therapy. This is an interesting randomized study where they randomized patients to 3 areas of treatment with this BiCAP device, and then at the end treating right on the lesion compared to just treating right on the lesion. And as you can see there, overall hemostasis was significantly higher with the former approach. Now here, I just want to make a comment about gastric antrovascular ectasia, where traditionally we have used some type of thermal therapy, whether it's argon plasma coagulation or radiofrequency ablation. However, more recent studies seem to suggest that band ligation may be more effective in eradicating GAVE as well as leading to decreased need for transfusion and procedures. These figures at the bottom, I just put in there to remind us that you just need to be aware and understand the scopes that you use, because the biopsy channel are located at different spots, depending on what scope you're using. If you have access to a large bore gastroscope, that obviously can be very helpful with upper GI bleed cases, and sometimes you may need to use a side viewing scope to get the best visualization. Now, hemostatic powders, on the top there you see a randomized non-inferiority study looking at TC325 used in non-variceal upper GI bleed as primary therapy. And what you find there is their primary outcome was control of bleeding within 30 days, and the hemostatic powder group was not inferior to standard treatment. The bottom cartoon is from a more recent RCT using a different polysaccharide hemostatic powder for peptic ulcer bleeding with similar outcome. They were randomized to the hemostatic powder versus standard care, and initial hemostasis was comparable, as well as rates of rebleeding at 30 days. So suggesting that hemostatic powder can be used as initial treatment for bleeding. Now, as we might expect, it is very helpful for tumor bleeding, for which we've not had great therapy so far. And this was a recent RCT randomizing patients with active bleeding from a GI cancer to TC32 powder versus standard endoscopic treatment. And you can see here on the bottom left, 30-day rebleeding rate was significantly lower with the hemostatic powder arm. And this table just shows you the various hemostatic powders that are available throughout the world. The top 3 are the ones that we have available in the US currently. And I do just want to point out that the Medtronic product is a little bit different because active bleeding is not necessary compared to the Cook and Olympus products. Now, the over-the-scope clip has also been looked at as primary therapy in active non-variceal upper GI bleed in this randomized study compared to standard therapy. All of these patients in this RCT underwent repeat EGD within 3 days. And as you can see here, the primary outcome of clinical success, successful hemostasis without recurrent bleeding, was significantly better in the OTSC arm. However, for those of you who've used the over-the-scope clip, it's certainly sometimes not easy to use and may not be possible to use in certain locations. So I think we still need further studies to understand its role as primary therapy. Now, in terms of outcomes of endoscopic treatment, anywhere from 5 to 20% of the time, we're not able to establish initial bleeding control. Rebleeding occurs about 10 to 20% of the time. So the question is, can we do better? And the Doppler endoscopic probe that can be advanced down your biopsy channel may help with that. So this is an RCT looking at non-variceal upper GI bleeding. And you can see there when Doppler was used, the 30-day rebleeding rate was lower. And so this is just an example of a case of mine, a patient who presented from an outside hospital, had initial treatment and then bled again. And you can see here, this is at the gastrojejunal anastomosis in the row-wide gastric bypass patient. I put all these clips at the bottom here, and at the end, I saw this little blip at about the 1 o'clock position. Was not 100% sure if this was a non-bleeding visible vessel. Placed the Doppler probe on there. I could hear the pulsations of the arteriole there, and therefore placed more clips on there. Repeated the Doppler probe, did not hear any more pulsation, and the patient did well without further rebleeding. Now, after endoscopy, what should you do? Well, for those patients with low risk of rebleeding, just feed them immediately and discharge them immediately. They should be placed on daily PPI with appropriate follow-up per GI, and of course, check H. pylori. For those patients with higher risk stigmata for rebleeding, you should watch them for 72 hours, and they should be administered high-dose PPI during this time, and then discharged on BID PPI for 14 days. The question of diet still remains a little bit unresolved. It's not entirely clear how we should handle that in these higher risk patients, and how quickly we can resume solid food in these patients, but perhaps sometime in the first 24, 48 hours. Now, routine second look EGD has been shown not to improve outcomes, but you should consider it if you did not visualize things adequately during the initial endoscopy, feel like you didn't render adequate therapy, patients has a high risk of rebleeding, or of course, if you think the patients are having recurrent bleeding. And absolutely, the first thing that should be done is repeat EGD when patients are rebleeding, because with that second EGD, we're able to prevent rebleeding 75% of the time. The one thing I'll say is that if during the initial EGD thermal therapy was used, you probably want to avoid doing that again the second time because of concern for potential risk of perforation. And this is certainly where the over-the-scope clip seems to be helpful. This was a study looking at recurrent peptic ulcer bleeding. Patients were randomized to the OTSC versus standard therapy. And you see how rebleeding was significantly lower with the OTSC arm. So to summarize, transfused patients when their hemoglobin goes less than 7 or less than 8 for patients with cardiovascular issues or if they're hemodynamically unstable. The goal is to pretty much normalize the INR. However, the INR does not need to be normal before doing your procedure. Platelets, usually we say over 50,000, and hold all NSAIDs, blood thinning agents, if possible, You do not need to hold aspirin, however, if it's being used for secondary prophylaxis. You can consider pre-endoscopy IV PPI, although again, this has not been shown to help with any meaningful clinical outcomes. You can certainly give patients IV erythromycin, perhaps metoclopramide, and perform the EGD within 24 hours. During the EGD, of course, treat bleeding lesions, non-bleeding visible vessels, and potentially ulcers with overlying clot. You can consider injecting epinephrine and then carefully cold guillotining those off to try to expose the underlying lesion. Again, do not do monotherapy with epinephrine injection. Consider bicapping in 3 areas around the bleeding lesion as well as on the vessel. Hemostatic spray does not seem to be inferior to standard of care in treating active upper GI bleed, although it should be reserved for when standard therapy fails, is not possible, or definitely as primary therapy for tumor bleeding. And in terms of ways to reduce recurrent bleeding, high dose IV or oral PPI for the initial 72 hours for high risk lesions. Consider using Doppler probe, repeat EGD in select cases, and consider using the over the scope clip. All right, so let's move on to lower GI bleed now. As you can see there, diverticulosis still leads the pack in terms of etiology of bleed, and this just shows you a non-bleeding visible vessel within a tick and clips being placed carefully right on the lesion. So as you might expect, if you see a lesion that's bleeding or it's a source of bleeding in diverticular bleeding, treating endoscopically is superior to not treating, and this is simply what this study says. In terms of how to identify a source in diverticular bleed, if you do the colonoscopy urgently within 24 hours, that's been shown to increase your chances of identifying the source, as well as using water jet, using a cap, and having an expert endoscopist do these procedures. Now, in terms of clipping, you can certainly, as I showed you earlier, clip right on the non-bleeding visible vessel, or you can just clip the whole tick closed if you can't actually see it, but you just see blood oozing out from the tick. And this study is suggesting that doing the direct clipping, so right on, for example, the non-bleeding visible vessel, may be superior in decreasing rebleeding compared to the so-called indirect clipping approach, where you're just simply closing the entire tick closed. Now, this study is comparing band ligation that you can see there versus clipping, and it seems to suggest that perhaps band ligation may be superior to clipping in decreasing late rebleeding. Now let's move on to talk about angiodysplasia briefly here, where if it is not bleeding and you encounter an angiodysplasia and the patient does not have a history of GI bleed, you should not treat because it is an incidental finding. Of course, if it's not bleeding, but the patient has a history of iron deficiency anemia without any other source identified, then you should treat it. Now, in our case, where we're talking about active lower GI bleeding, we of course want to treat it. And typically we use thermal therapy, which is highly successful. Now, I do want to make a mention about medical therapy for patients who have recurrent bleeding and are transfusion dependent. Hormone therapy does not have a role except for maybe in Osler-Weber-Rendu disease. Octreotide, however, does seem to be helpful. And I did want to point out this recent RCT that looked at octreotide, which was given as a monthly IM injection versus standard of care in patients with angiodysplasia-related bleeding. And these patients were followed, the study went on for a year. And what you can see there is their primary outcome was difference in transfusion between the two groups. And you see there's significantly decreased amount of transfusion needed in the octreotide group compared to the standard of care group. And whether or not endoscopy was performed was left to the discretion of the physicians in this group. But don't forget about octreotide. I do also want to say a word about thalidomide, that there was an RCT that suggested this may be helpful as well. Now, post-polypectomy bleeding, of course, is the #1 major complication post-colonoscopy. About half of the time it resolves spontaneously. And predictors of this happening, of course, include active anticoagulation use, left-sided polyp, use of a hot snare, and pedunculated polyp. So how can we reduce the risk of post-polypectomy bleed? Was certainly by using cold snare for small polyps. And you know, in 2024, we should really be using cold snare to remove most polyps, most all polyps that are less than a centimeter in size, unless they're incredibly small, and you can just remove them with forceps. Now, multiple studies have been done looking at the role of prophylactic clipping. And this is a meta-analysis that seemed to suggest that clipping does decrease delayed bleeding in polyps that are at least 2 centimeters in size. However, this randomized trial seemed to suggest that the positive effect of prophylactic clipping may be mainly in large proximal adenomas. For pedunculated polyps, injecting the stalk and doing prophylactic clipping does seem to decrease delayed bleeding. And you can also use an endo loop that you see a picture of here that you place at the base of the stalk, and you basically just strangulate the pedunculated polyp, let it turn purple, and then snare above. You can, these can be a little tricky to use because they're very floppy. And again, just using prophylactic clipping is reasonable as well. Now, radiation colitis, in terms of bleeding from this is a chronic issue. And what happens is epithelial atrophy with fibrosis, obliterative endarteritis with chronic ischemia, and this neovascularization that happens that can bleed. And certainly thermal therapy is very helpful, especially argon plasma coagulation. However, the patient needs to undergo a full colonoscopy preparation, even though all you're doing is a sigmoidoscopy to avoid perforation in these patients. And you do want to give them about a month or so break in between sessions to allow where you've done therapy to heal and the ulcer that you've created to heal. For kind of more difficult cases, there's radiofrequency ablation, cryoablation, and hyperbaric oxygen therapy. However, of course, the problem with hyperbaric oxygen therapy in particular is that it is quite an intensive regimen with a mean of 40 treatments required and not readily available. So in terms of lower GI bleed, this is more of a multidisciplinary approach guided by the patient. Certainly, colonoscopy is still the gold standard for both diagnosis and treatment. However, I do want to mention that if patients are bleeding severely, they're unstable, they can't be prepped for a colonoscopy, very reasonable, and those patients should be sent straight away to angiography. And those, the radiologist can certainly both diagnose and render therapy as well with angiography and surgery as backup. Now, in patients who are having more brisk bleeding and you're concerned they may actually have an upper GI source, remember about doing an EGD in those patients. Flexible sigmoidoscopy, not performed very commonly, but of course, if patient just had a colonoscopy with a left-sided polyp removed and now they're coming in with bleeding, certainly reasonable just to do a sigmoidoscopy in those patients. And then for diagnostic purposes, we do have radiology imaging with the multi-detector CT and less commonly used now, nuclear medicine tagged RBC scan. So for multi-detector OCT, the sensitivity for detecting a source of bleeding in active bleeding is quite high, as you can see there. Goes down significantly in patients with obscure GI bleeding. and specificity is quite high as well. So certainly if patients are able to have intravenous contrast, this is what we do initially. And patients should not be given any oral contrast, but just given the intravenous contrast to see if you can identify where the intravenous contrast enters the GI lumen. RBC scan that we're doing less and less nowadays is more sensitive still and relies on the use of protectinate labeled RBC scan, but as we all know, has issues with diagnostic accuracy and accuracy of localization. Angiography is not typically performed initially unless the patients are bleeding briskly because it requires a higher rate of bleeding for the radiologist to detect it. It should be performed within an hour of a positive tagged RBC scan or CT angiography. And rebleeding rates occur up to 50% of the time, seems to be lower with diverticular bleed compared to bleeding from AVMs, for example. And embolization-specific complications seem to be far lower nowadays. So the nice thing about radiology is that the patients don't need to take any preparation, and you can certainly evaluate the entire GI tract. However, the issue with tagged RBC scan and CT angiography are that they're only diagnostic. And of course, there's issues with radiation exposure. Patients with renal issues or IV dye allergy cannot be administered IV contrast, of course. And then the problem with time lag between radiology exams, where if the CT angiogram is positive, but then it takes them several hours to get to the angio suite, by that time, the bleeding most likely has stopped. So again, to summarize the approach, for patients with low risk lower GI bleed, those that are stable, start prepping them for a colonoscopy. You can consider an outpatient exam and select patients only guided by the Oakland score being less than 9 and patients who are very reliable and live close by. On the other hand, if patients have severe lower GI bleeding, they're hemodynamically unstable, you want to try to exclude an upper GI source if you can get them to an EGD safely. Otherwise, send them to angiography straight away and consider having your surgical colleagues on board. For patients with ongoing lower GI bleed, so they continue to pass hematochezia, but they're stable, they're not prepped yet to do a colonoscopy, certainly start the prep, consider an upper GI source, and perhaps do an EGD even before they're fully prepped for a colon. And you can certainly think about using CT angiography to help identify a source of bleeding. So take-home points for the GI bleed portion of the talk. Resuscitation is very important and should be done with at least 2 large bore IVs. The patient should be transfused to the appropriate hemoglobin goal. Consider if the patient may truly have an upper GI rather than a lower GI source. If the patient has a non-varicose upper GI bleed, consider an IV PPI drip or BID bolus before upper endoscopy, IV erythromycin or perhaps metoclopramide before endoscopy. EGD should be done within 24 hours. For lower GI bleed, it's more of a multidisciplinary approach that's tailored to each patient. Again, angiography straight away should be considered for those who have severe unstable bleeding. It's often preceded by CT angiogram if the bleeding is less severe and ongoing, and certainly reasonable to do CT angiogram if the patient isn't prepped yet to do a colonoscopy. For diverticular bleeding, it's helpful to use a cap. Look carefully for a source, both while you're going in with the scope as well as coming out. Clipping the vessel itself may be superior to clipping the entire tip closed. Banding appears to be effective and safe as well. Argon plasma coagulation for bleeding AVMs and radiation proctitis are very effective. And certainly for patients with transfusion-dependent bleeding from AVMs, should be placed on octreotide. Ways to decrease risk of post-polypectomy bleeding include cold snaring for small polyps, certainly almost all polyps less than 1 centimeter in size, clipping polyps that are over 2 centimeters in size, and perhaps prophylactic clipping or use of endoloop for the large pedunculated polyps. All right, so let's finish up by talking about foreign body management. So in terms of history, again, targeted history, asking about what they swallowed, how many of whatever they swallowed, when they swallowed it, and the timing of the onset of symptoms. Remember that the location of dysphagia is not necessarily a reliable indication of where the object may be impacted, because distal impactions may actually be referred up to the throat. And physical exam, of course, you're looking for any signs of perforation, and see if they're just not able to tolerate their own saliva, which indicates complete esophageal obstruction and is an emergent indication for EGD. About 10 to 20% of the time, we need to do EGD for foreign bodies. And as far as radiology goes, really the reason to do this is if you're suspecting complication and if you're trying to figure out where radiopaque or unknown foreign body may be. Food impaction, x-rays are not necessary unless, again, you're concerned about the complication or that there may have been a bone in what they ingested. Absolutely do a CT if you're concerned about perforation. Do not give these patients barium or gastrografin, though. Now, there are some times where no endoscopy is indicated. So certainly if the patients have no symptoms and they swallowed a blunt and small object, except for batteries and magnets, very reasonable not to do an endoscopy and just observe. And if you're suspecting body packing, you also do not want to scope these patients because you don't want to accidentally tear the drug pack and potentially cause them to die quickly. So in terms of the issues faced with endoscopy, of course, it's the issue of timing. Do we need to come in right now? Or can we, do it first thing in the morning or later? Of course, always be mindful about protecting the patient's airway. And I would have a low threshold to intubate these patients to protect them. You can certainly use an overtube, especially should use this for sharp objects, things that are difficult to grasp because you don't want to lose a hold of them and then they go down their trachea. Or if you have to go back and forth, in and out multiple times, trying to retrieve large food impaction, bolus, or multiple objects. You want to review all the available tools, plan and practice. So this is certainly not an exhaustive list of equipment that's available, but things that you should know where they are and how to use. Example of overtube there. Caps can be very helpful in food impaction that I'll talk about in a minute. The hood is fabulous for sharp objects to protect the esophagus and various different grasping forceps, retrieval net, and different snares as well. And of course, this makes sense, but something to remember with sharp pointed objects, advancing points punctured, trailing do not. So when you look at the safety pin, you never want to pull up a safety pin with a sharp end pointing up like this. You want to push it down into the stomach, reverse it, and have the sharp end trailing. And use an overtube or a hood as shown down below. Now, for management of things in the esophagus, emergent EGD now should be done for patients with evidence of complete esophageal obstruction. So patients who are just sitting there, just drooling, not able to tolerate their own saliva, patients that you think have a sharp pointed object or batteries in their esophagus. Those are emergent. Otherwise, everyone else should be done within 24 hours because the risk of perforation does go up after that. Now, for things that are in the stomach, you do want to do the EGD within 24 hours for sharp pointed objects, magnets, batteries, and long objects, within 72 hours for medium-sized blunt objects. And I'll just say a word about Bezor. Try to have the patients drink a lot of Coca-Cola quickly. Don't use papain. And if you're going to do endoscopy, you have, all these various tools available to try to chop the bezoar down into, pieces that are smaller than a centimeter, so hopefully they can pass. But these can be very difficult procedures. So food impaction, I know we all use IV glucagon. There's a recent randomized trial that was done giving patients IV glucagon versus placebo, showing that there was no difference in presence of objects and how quickly you were able to deal with the foreign body during endoscopy. However, I think we'll still continue to do this. And oftentimes you're able to just very gently push the food bolus into the stomach, but obviously be very careful and assess for obstruction distal. And if it's a huge amount of food, again, I think you should intubate the patient or at the very least use an overtube and have a variety of tools available. If it's feasible to do this after you've cleared the food impaction, certainly biopsy to look for EOE and or dilate if there's not a large ulcer or significant inflammation. This was a randomized study showing the benefit of using this soft oblique cap versus in the conventional group, where the technical success rate, as well as the rate of en bloc removal, the retrieval time was all so much better when you use the soft oblique cap. So certainly something to have in your armamentarium. Button batteries in the esophagus, I mentioned earlier, this is an emergency. So you want to remove this ASAP and protect the airway. There are various different techniques to retrieve this, but do not use graspers or forceps. That might just pierce through the button battery. If it's already in the stomach, do the EGD within 24 hours. And if it's already passed and beyond the duodenum, do serial KUBs. For coins in the esophagus, if the patient has no symptoms, you can certainly watch for 24 hours and then do the EGD if it's still present. On the other hand, as I mentioned earlier, if there's, signs, symptoms of complete esophageal obstruction, do the EGD emergently. If the coin is in the stomach or beyond, really don't need to scope them and put them on a regular diet and you can follow them. For magnets, you want to image the patient so that you know the total number and location of the magnets because you want to try to remove all the magnets that are within reach of your scopes. Now, if you are not successful with endoscopy, you do want to admit patients with sharp objects or batteries because bad complications can happen with those folks, and do daily x-rays for patients with sharp pointed objects. If the batteries have gone beyond the duodenum every 3 days, and certainly you can have surgical colleagues following along, especially if the object has gone beyond the ligament of Treitz and is not progressing any further after several days. Colorectal objects, if it's a sharp object, don't do a rectal exam, use a hood. If it's a large object, as you see there, like a vibrator or a bottle, it may require anal sphincter dilation. This can be very, very difficult to remove endoscopically. And I'll finish up by saying just a couple words about caustic ingestions, which we don't see as much in adults. However, it's incredibly important not to induce vomiting in these patients and get a CT of the neck, chest, abdomen, looking for evidence of complications. EGD should be performed immediately, but within 48 hours to stage the degree of damage that's been done and which allows you to predict the course that the patient will undergo. And this is the grading. So 0 is normal findings. 1 is some erythema, edema of mucous membrane. 2A is when you see friable mucosa with erosion, pseudomembranes, and superficial ulcerations. And once somebody has reached the 2A stage, this is where they're at increased risk for bleeding, fistula, perforation, as well as later stricture formation. 2B patients have all the findings of 2A, plus now deep, discrete, or circumferential ulcers. 3A, they have massive congestive ulcerations and small necrotic foci. And 3B is when they have all the findings of 3A plus extensive necrotic foci. PPI can certainly be used, although it's unclear whether they really do help. In terms of strictures in these patients, I think we're all aware that our ability to deal with these endoscopically are far less successful than, for example, peptic strictures with a much higher risk of perforation. And if you suspect esophageal stricture, then you can do the initial dilation about 3 weeks after ingestion and then repeat it every 1 to 3 weeks. You can also do triamcinolone injection, use mitomycin C or fully covered esophageal stent to try to help with these difficult strictures. So to summarize, know the indications for emergent EGD, which include complete esophageal obstruction, presence of sharp object button batteries in the esophagus. The indications for urgent EGD within 24 hours is anything in the esophagus that does not meet the emergent criteria. And then in the stomach, sharp objects, long objects, magnets, and batteries. Certainly the contraindication for endoscopy is if you suspect drug packets. Remember to protect the airway, be familiar with all the available equipment that you have, and don't forget about using a cap, especially with food impaction cases. Plan and practice your strategy before you do the endoscopy. And for caustic ingestions, EGD should be performed within 48 hours of ingestion. And if it's gone beyond that period, then you should not scope those patients. So thank you very much for your attention.